So my topic is genetic counseling in ART. I'll discuss what are the indications when we get references, what kind of cases, what are the genetic indications that we identified needs assessment, evaluation, and what are the future direction when they are planning pregnancy, IVF, XA, what are the testing that are indicated, and how we counsel them, the pre-test and the post-test counseling. These are the common indications. Patient might just have infertility. They want to understand what is the cause. Most common question that I always get from patients. To understand what is causing it, we want to identify that. So maybe they don't have any family history. There can be cases where there is some family or obstetric history, but they don't have anything identified. So they want to know what is the cause, and they have this fear and they're anxious that it should not have recurrence in our future pregnancy. We are planning IVF, we don't want that to be inherited. There are cases of recurrent pregnancy losses, no other family history. They just come with this indication, recurrent implantation failures. They had multiple IVF cycles which has failed. There can be advanced maternal age. They want to understand, patient wants to understand why. They know this terminology, they have been already told by the IVF specialist, but they want to understand what is it and why is it a risk factor and what to do. Previous genetic reports to review and for further plan. There are some patients who already had a counseling maybe in the past, or any previous child who was affected had indication of a genetic condition. They already have gone tested, the genetic cause is identified. Now they are planning the next pregnancy and want to understand what are the test options that they have that they can include to prevent this in the next pregnancy. Also about the prenatal screening and diagnosis options. Even when the patients, they're planning IVF, they want to know, do they have to, they are already told that after the IVF, we do a PGT testing. You may have to, after the pregnancy is confirmed, there will be some prenatal screening, the regular ones, as well as the prenatal diagnosis that you need to go ahead with. So these are the general indications that we get in a patient where we get for genetic counseling. Most common genetic association. So when we have a patient with any of the indications that I just now discussed, we have to explain not everything is always genetic, especially recurrent pregnancy losses, recurrent implantation failure, but yes, it can also have a genetic factor. So what are the genetic association based on the indication? It can be a chromosomal abnormality where we look for the karyotyping, or maybe the previous pregnancy chromosomal microarray report. It can be a single gene disorder, so gene sequencing report. If they have, we can explain about it, we can test what are the, tell them what are the test options that we can include with the PGT, or we can start the evaluation, come to a conclusion, identify the genetic risk for the family, and include the appropriate PGT for them. There are some conditions which can be polygenic or multifactorial causes are included. Like for example, if a patient comes with rheumatoid arthritis, ankylosing spondylitis, these are multifactorial conditions, but still they don't want the child to inherit. So for these multifactorial causes, we have to be very clear that multifactorial, there can be a genetic cause, but there are other environmental factors or lifestyle factors also which increases the overall risk. And we don't have the genetic factor which are associated with these conditions are not the only factor or not the diagnosis which we can include in the PGT. So there are ethical issues. That genetic cause is not the only cause. We cannot ethically, that will be wrong to check for that genetic factor and discard the embryos, because that is not the only cause. It's not sure that the child will have the condition. There are also male infertility genetic factors like Y chromosome microdeletion. If in the semen analysis report, azoospermia or severe oligospermia is identified, this is the test we always recommend, if not done already. Now I'll start with the chromosomal analysis. Karyotyping of couple. Any couple with infertility, recurrent implantation failure, recurrent pregnancy losses, early first trimester, second trimester miscarriages, or any abnormal ultrasound finding in the previous pregnancies. For these cases, it is very important that we first do the karyotyping of the couple. We identify if there is any rearrangement. If that is normal, okay, we can just go ahead. We can tell that the most common chromosomal factor is not associated in your case. But if there is a rearrangement identified, like translocation, insertion, we can decide a PGT, that is PGT-SR, for structural rearrangement, include that with their IVF or ICSI. Next, one more report is chromosomal microarray, but it is very important to understand the previous indication that I was talking about, recurrent implantation, failure or infertility. For those patients, chromosomal microarray is not the appropriate test. We should always do karyotyping because chromosomal microarray is NGS-based testing where we will identify any unbalances. Chromosomal microarray will not identify any balanced rearrangement because there is no loss or gain. Chromosomal microarray is more appropriate if they have an affected child already. For common examples are dysmorphic features, mental retardation, delayed milestone, or product of conception. If there is an early pregnancy loss, we want to identify if there are any unbalances like microdeletion or microduplication. For those cases, or a prenatal diagnosis if there is any abnormal ultrasound finding. This is for an affected individual, a child or a pregnancy. The third type is high resolution banding. So where to offer high resolution banding? Suppose there is a strong indication that maybe one of the partner in the couple has a rearrangement and we can include PGT-SR. It is as per the ESHRE guidelines, it is better to go for a high resolution banding, that is a higher resolution karyotyping, because in the regular karyotyping, sometimes the band resolution, the breakpoints, in case there is a rearrangement, might not be appropriate that we can go ahead with the PGT-SR. In those cases, we have to ask the patient to do a high resolution banding. So wherever possible, with those indications for couples, it is better to go for a high resolution banding first. Now, single gene defects, we know there are many common examples like cystic fibrosis is one factor, one condition that you all come across, cases of infertility, thrombophilia mutations for a female with recurrent pregnancy losses. Single gene, there are multiple genes associated with spermatogenesis or oogenesis, infertility, RPL or RAF, or a genetic syndrome, maybe a family history or obstetric history or an affected child available. So with all these evaluation, the indications that we have for a patient, when we identify there is a genetic risk, based on the cause, if it is chromosomal or a single gene defect, we decide on what will be the appropriate pre-implantation genetic testing or PGT. So PGT, we know previously the old terminology was PGS or PGD. Now these are known, PGS is now known as PGTA for aneuploidies, that is numerical defect. These are for cases where the couple is not identified with any chromosomal rearrangement, but there is other factor like advanced maternal age, where we want to rule out any aneuploidies in the embryos. Next is PGT-SR, structural rearrangement, where the couple, one of the partner is already identified with a chromosomal rearrangement, and we know that this can lead to unbalances in the pregnancy or embryos. Third one is PGT-M for monogenic disorder, the single gene defects that we were just now discussing. If there is a single gene defect identified, the risk identified, couple is identified as carrier, or maybe one of the partner is already affected and has a single gene defect. For those cases, we can include it for PGT-M analysis in the embryos. So I'll start with the PGT-A or PGT-SR testing were indicated. So for these cases, like advanced maternal age, RPL, severe male factor, or RIF, the documents that we always look for, we need the genetic factor, whether it's single gene or chromosomal, we need the genetic risk identified. So we have to check whether the karyotyping is available or not, the reports are available or not. The chromosomal microarray in cases of the affected child that I just discussed with you. So these reports are important. Now for PGTSR, one very important point, if there was a previous pregnancy or if a couple has a child who is affected and identified with a microdeletion, microduplication in chromosomal microarray, further we do testing for the couple karyotyping, and we identify that the couple has a rearrangement which has caused that unbalance in the pregnancy, which was identified in the CMA report. We also check for the breakpoints. The CMA, whatever unbalances are identified, does that correlate with the parent's rearrangement identified in the karyotyping? That correlation is important because the breakpoint should match, where we check a case whether we can go ahead the feasibility for PGT-SR, whether it is within the resolution to check, identify all the breakpoints, the unbalances in our PGT-SR study. Also, for these cases, the family history and obstetric history is important. Maybe, suppose one of the partner is identified with a rearrangement, they have an affected child, they may or may not have, or a previous pregnancy. And when we take the pedigree, when we do the pedigree analysis in the family history, we also see there are other children maybe or other couples in their family who had similar obstetric history. So these cases, once we know what is the family history, their obstetric history, we can also suggest who are the other family members at risk who needs to be evaluated. And it will be helpful for their pregnancies, that what testing should be done. So based on all this, the case description as well as the appropriate genetic reports, we can decide on the PGT-SR or PGT-A analysis for those couples. PGT-A, one very important point, you must be coming across many karyotype reports where there is a normal variant identified, like chromosome 9 QH+, chromosome 1 QH+. These are normal variants. There are different default description in those reports that we will you identify at different labs. Some may say this is just a normal polymorphic variant. Some may say there are some studies which suggest that this can be associated with infertility or bad obstetric history. We do not have enough scientific evidence yet to say that these normal variants can be associated with bad obstetric history. But yes, there are some population-based studies which suggest that if one of the partner has these normal variants, this might be associated with pregnancy losses because this makes the chromosomes unstable. But we don't still have scientific evidence, but those cases, when they are planning next IVF or ICSI, we can suggest, especially when we see there is a bad obstetric history, we can always suggest PGT-A for these cases because even though we don't know whether there is a scientific basis for that, but there are some studies which shows that this might be associated with unbalances in chromosome in pregnancy. Now coming to the PGT-M for single gene defects. When we take the family history, the main reason is first to identify or understand what genetic condition or syndrome this looks like. If there is a family history of a child affected or a previous pregnancy with abnormal ultrasound identified, first thing is to check and try to understand what this could be. Other point is when we take the pedigree, the detailed family history, we also try to understand what is the inheritance pattern also associated with the syndrome that we are suspecting in the family. So there are mainly 3 types of inheritance pattern, and this helps us understand or fit any symptoms or clinical presentation in a family, that what kind of condition it might be. The first one is autosomal dominant. Autosomal dominant may be there is an affected partner, one of the parent is affected, identified with an autosomal dominant condition, like for example achondroplasia, several skeletal dysplasias, where one of the partner is already affected. We have identified the cause, heterozygous variant, and there will be 50% chance in every pregnancy, irrespective of the gender of the child, that the child will have risk, 50% chance of being affected with that autosomal dominant condition. The second one is autosomal recessive, where both the partners, they are unaffected, they don't have any clinical presentation, but based on the previous genetic evaluation that we have done for an affected child and tested the couple to see if they are carriers, they are just unaffected carriers. In those cases, in every pregnancy, there is 25% risk. But one important point here, like the previous one I told you, this will be heterozygous. That is, one of the allele has a mutation. In autosomal recessive condition, there should be both the variants, that is both the alleles. There should be a homozygous mutation identified in the child. There will be some cases where you will see it is inconclusive report. A child, they have done a multi-gene testing or a single gene testing by NGS, identified only heterozygous mutation, which has an autosomal recessive pattern of inheritance. That means that report is inconclusive. We don't know what is the other mutation. It might be a large deletion or duplication. So it is very important to come to a conclusion and identify the genetic risk and also confirm the carrier status in the parents in autosomal recessive conditions. This is again irrespective of the gender of the child. The third category is X-linked recessive, where females are carriers, and if a female is carrier, the mother is carrier. For all male children, there will be 50% chance of being affected, 50% chance of being not affected, and 50% chance of female progeny to be a carrier or 50% chance not to be a carrier. That means for X-linked recessive, when the mother is carrier, most common example, DMD, Duchenne muscular dystrophy, where if the mother is carrier, she is unaffected, but male children will have 50% chance of being affected. So with all these, after we do the genetic counseling, we first identify what syndrome it is. If the testing is not done, we select the appropriate test to identify what is the gene variant associated, the disease-causing mutation in the family, and based on this, we can decide the pre-implantation genetic testing, that is for monogenic disorders. So PGT-M, this allows specific selection of non-affected embryos before implantation in couples at risk of having affected offspring based on the genetic counseling, the genetic testing, and the risk assessment that we just now discussed. Also with PGT-M, wherever indicated, we can include HLA compatible or HLA matching, like common indications for such cases are the thalassemia or sickle cell anemia. We can include the HLA matching. If there is an affected child and they want the next child to be, to see if the child is donor for bone marrow transplant for the previous affected child. So PGT-M, this is an alternative to prenatal diagnosis for those couples with known risk of transmitting a genetic condition to their offspring. There are some cases when we get for genetic counseling, the couple, maybe they are already identified with a genetic condition, they are carriers or they are themselves affected with an autosomal dominant condition, but they did not opt for IVF because there was no fertility issue. So they had natural pregnancies and had to undergo prenatal diagnosis. So in prenatal diagnosis, the limitation is it is either affected, not affected, and they need to decide on the pregnancy whether to continue or not. So this is a very nice tool for such couple. They don't want to go through the whole process of prenatal diagnosis and take a decision about the pregnancy. For those couples, this is very useful. And in the pre-test counseling, we check for the genetic reports, the family history, we give a genetic counseling letter, we make sure that the couple, the family has been explained in the language that they understand. They identify all the limitations, advantages, and what to expect in the PGT testing that will be done. And one very important point for PGT-M cases, if the patient is planning ICSI or IVF with PGT-M, a pre-PGT-M workup is mandatory for these cases. So we cannot directly do PGT-M on the biopsies. We need to first do a pre-PGT-M workup where we evaluate the case, we check for what blood samples are required for that case to do the analysis. In conclusion, so genetic risk assessment is one important factor that we do. The non-genetic factors are explained to the patient. Not everything or all indications are genetic. The advantages and limitations are explained to the couples. Pre-test counseling by the IVF specialist and the genetic counselor is very important. So this goes, together. There are few aspects that the IVF specialist will explain, and next the genetic counselor explains. Chromosome analysis reports for PGTA and SR is important. Pre-PGTM workup is needed before the PGTM. PGTM and PGTA can be performed on the same biopsy, so you can combine these two analyses. And post-test counseling to understand or interpret the report is important. Prenatal screening and diagnosis options are discussed, and follow-up of PGT pregnancies and the children is important. Thank you.